I completely agree with those comments about symptom control outside of phlebotomy control and hematocrit control and splenic volume reduction. I think we now have more tools for treating patients, and we alluded to one earlier, and that was the pegylated form of interferon, and Ruben alluded to the updated EHA. Serge, do you want to tell us about the PROUD-PV study?
Yeah, I think we are talking here about the major development in polycythemia vera arena in terms of the new therapeutic options. Perhaps many colleagues in the United States do not really know that a year ago there was approval of ROPEG interferon, what I call a super long-acting interferon in Europe for polycythemia vera patients. It's given under the skin every 2 weeks, and after a year you can even switch to once a month. It was approved to be given to patients with polycythemia vera for control of the blood cell count. The goal is complete hematological response, not in patients with very big spleen, because perhaps it's not very well given for patients with big spleen. So in that setting, the drug has been superior after about 3 or 4 years of therapy to hydroxyurea. That was the PROUD study that you mentioned, the randomized study between hydroxyurea and ROPEG interferon in patients that were either newly diagnosed, not previously treated with cytoreductive therapy, or already on hydroxyurea for some time, but not optimally managed. So not refractory, not resistant, but there was room for improvement. In that randomized study, at the initial analysis after 1 year, there was no superiority of interferon, but we know that interferon takes time to work, and after several years, 3 or 4 years, superiority was seen. Regardless of the comparison to the hydroxyurea, the label allows its use for polycythemia vera, and it doesn't really talk about first line, second line, superior, inferior to hydroxyurea, which is according to the European Leukemia Net guidelines and NCCN guidelines as well. Ruben described this very well. The guidance would say cytoreductive therapy and hydroxyurea or interferon. And now, at least in Europe, and hopefully soon in the United States, we'll have a ROPEG interferon to offer to our patients, much less toxic, better efficacy when you have less toxicity. And I'm looking forward to embrace this in our own patients here in Texas.
Okay, before we move on, any other comments about what's coming, what's new in PV? I think that really was the major highlight coming out of EHA. One final question about the use of interferon. It's been touted as something that is actually more of a disease-modifying agent, because some earlier studies showed decreases in, for example, the JAK2 allelic burden. Has that been shown? Can you tell us about that from the PROUD-PV or other randomized trials? Serge?
This particular information is quite interesting, because this is the only therapy that may, in some patients, even eliminate the JAK2 clone by virtue of not being detected by our sensitive testing. That has been noted in the past with commercially available long-acting interferons Pegasus in clinical studies. This is, of course, offline use of that medication. But in ROPEG interferon studies at last ASH, there was a similar report about 10 to 15% of the patients achieving the molecular response, not detectable JAK2 mutation anymore. Now, we hope that that means a lot for these people, and that means not perhaps a cure. We don't associate this to the cure, but if you have no detectable JAK2 mutation, that would mean there is perhaps no or minimal malignancy there anymore, and that would perhaps translate in a long-term benefit for these patients in the future. So something to follow. It's not the goal of the therapy, but it's very interesting qualitative studies that is evidence of the biological ability of these medications to alter, possibly, the natural course of the disease.